I'll request her to please start her presentation.
Thank you, sir, for the opportunity and the kind introduction. So my topic is genetic testing in a case of strabismus. So what are the questions which come to the mind while we think about the genetics in strabismus? So is there any role of genetics in strabismus? And when to do, if there is a role, when to do genetics in strabismus and why to do? Will it help in managing the case better? So I will be focusing on these points. So what does the literature say? About the twin and family studies, Hippocrates first noted that strabismus run in families. And twin studies have supported a strong genetic contribution, particularly for ESO deviations. Monozygotic twins have concordant rates of strabismus around 50 to 82%, and in our clinic also we have found 2 monozygotic twins having ESO deviation at the same time. So is there any, is strabismus a Mendelian disorder? In large strabismus pedigrees in which strabismus is inherited is in apparently Mendelian pattern, several studies have used linkage analysis to identify the potential loci. And one of the loci is 7p22.1 STBM1, which was mapped in one large family. So what does the genome-wide association studies tell? The diseases that are common in the population often have multiple genes that contribute, with each individual variant having a small effect size. And one of the studies on non-accommodative esotropia, 826 patients of European ancestry from the USA in discovery cohort and 689 patients from Australia and United Kingdom in the replication cohort have found functional single nucleotide polymorphism in the intron region of the WRB gene on chromosome 21. So coming to the copy number variants and single nucleotide variants and genetic syndromes, I will be showing with the help of cases. So coming to the case 1, an 8-year-old male presented to the eye clinic with congenital severe ptosis with poor LPS, infraducted eye position and chin-up head posture. His birth and development history were normal. The best correctal visual acuity was 624 and he had compound hyperopic astigmatism. Anterior segment was within normal limit. Posterior segment had subtle disc pallor. So he had positive family history. When we charted his family history, it dates to around 4 generations. And you could see his father also having the same problem. So when we assessed him in a detailed manner, we found that you can see that both the eyes are infraducted. The eye is not able to come in the primary position. And you could see there is a perverted convergence in up gaze. And there was a divergence in down gaze. And also there was an adduction deficit in the left eye along with some down shoot. So when we did an MRI, we found that the third nerves were attenuated and even the 6 nerves were attenuated. On the quasicoronal MRI orbit images, we could find that the superior rectus were very, very thin and even the medial rectus were very thin and even the inferior oblique. And there was a Y-shaped accessory muscle at the back of the orbit. When we saw the MRI brain images, we saw that there was an area of parenchymal atrophy with marked thinning of adjacent cortical gyri and subtle adjacent intraparenchymal T2 hyperintense signal in the right paramedian and occipital region, thereby implying that there was some CNS abnormality. Also, there was subtle thinning in the splenium and posterior part of the body of corpus callosum. So, this was, since there was a CNS abnormality, so it comes under CFUM3 phenotype. But to our surprise, when we did a genetic analysis, we found that it was KIF21A. So points to ponder is that brain malformation, which are characteristic of CFUM3 phenotype, and CFA3 generally have TUB3 mutation, but only KIF21A rarely. So our case shows the possibility of CNS abnormality with KIF21A. So this may be because of the phenotypic overlap between the TUB3 and KIF21A mutations, which suggest a shared disease mechanism underlying the two disorders. And just a word about the pathophysiology, this kinesin dimer basically attaches and moves along the microtubule, which is critical for the human nervous system development. So this mutation which we found in our case were not with a novel one because it didn't match with the literature search which we did. So take home message is that genetic can add a pathophysiological understanding of the complex condition and can help in genetic counseling. Certain missense mutations in KIF21A can harbor CNS abnormalities. Hence, genetics can further explore about the interdependent relation of KIF21A and TUB3 gene in disease pathogenesis. Now coming to the case 2, a 16-year-old female presented with inability to elevate in elevate the eyelids, and there was both eye were infraducted. Birth and development history was normal. The best corrected visual acuity was 6/18, and there was again compound hyperopic astigmatism. Anterior segment was large, and posterior segment there was 0.7 cupping suspicious, but though glaucoma was not there. Chin up head posture up there. This was his mother having the same presentation. So this is a short video showing the both eye ptosis. There was upgaze palsy. The globes were infraducted. The chin up head posture was there. There was a perverted convergence in attempted upgaze and divergence in upgaze. So you could see there was only horizontal movement was there, and there was no up or down movement. So this is again the CFEM1 phenotype, because both ptosis, upgaze palsy, infraducted globe position. This is the classical picture in CFEM1. So when we did an MRI, we saw that the third nerves were hypoplastic, but 6 nerves were normal. The superior rectus was quite hypoplastic, and MR was also little on a thinner side. We did a dynamic MRI orbit, and we saw that there was a perverted convergence. We could document the perverted convergence. As you can see, the thickness of the medial rectus was increasing in the up gaze, and the lateral rectus were thicker on the down gaze. So we could prove it on the dynamic orbital imaging. So, but when we did a genetic analysis, we found that it was TUB3. So there was a deletion of 19.3 kb, which was a very large deletion. So points to ponder in this case is, our case was a CFEM1 phenotype, which is mostly related with KIP21A gene mutation. And because TUB3 mutation generally presents as a more heterogeneous phenotype with unilateral and asymmetrical involvement. So single nucleotide variant in TUB3 mutation can present as CFEM1 phenotype, and heavy deletions can cause aberrant regeneration. So this is the patient. We did a bilateral IR recession, and along with PTSO and superior oblique suture spacer. This was the first post-operative photograph, and then we did a bilateral LR recession with upshift, and this was the final outcome. So takeaway points are: the higher the load of deletion in KIP21A gene can cause more severe aberrant regeneration, and careful stage surgery should be planned to reach the good outcome. Now the last case, a 16-year-old female presented with outward deviation since birth. Birth, development, and family history were not significant. Visual acuity was 6/9, 6/24. There was an anisometropic amblyopia in the left eye. Anterior and posterior segment were within normal limit. Hirschberg showed left eye hypertropia of around 45 degrees. So you could see that there was a hypertropia in both the lateral gazes, and you could see in the down gaze there was inferior rectus underaction, and in the up gaze there was superior rectus overaction. So either we are dealing with inferior rectus palsy or inferior rectus aplasia, or we are dealing with superior rectus overaction. So we did an FDT, and we found that the superior rectus was extremely tight. We were not able to move the eye. And active fourth generation test for the inferior rectus was present. So we did an MRI, and we saw that there was a superior rectus hyperplasia in the posterior orbit. So you could see here the global fibers as well as the global fibers as well as the orbital fibers were very thick. And we did the image, the third nerves, when we imaged, the third nerve was hypoplastic on the left side. So we did a left eye SR large recession of 16 mm, but still there was a residual hypertropia of around 15 to 20 degrees. So we again did a IR plication of 7.5 mm along with the IOANT, and we got a good surgical outcome. You could compare the down gaze. The down gaze has become much better, and though there was slight underaction in the up gaze, but the patient, it didn't bother the patient much. So when we did a genetic analysis, we found a ROB gene positive. And this ROB gene is the same gene which controls the neurite outgrowth and axonal fasciculation. And the slit proteins, a family of secreted chemorepellents, are ligands for ROB proteins, which regulates myogenesis. So that's explain our case. So ROB3 is also been implicated. The loss of function has implicated in horizontal gaze palsy, along with the scoliosis, which we have published in our previous paper, and it is associated with butterfly-shaped medulla and absent facial colliculi. So to conclude, with a prevalence of 2 to 4% in the population, strabismus can lead to loss of binocularity and amblyopia if left untreated. By uncovering the genetic factors contributing to strabismus, genetics can facilitate early identification of at-risk individuals, potentially paving the way for novel preventive and therapeutic strategies to mitigate the associated visual impairments And congenital incomitance strabismus, especially the CCDDs, do have a genetic foundation which needs to be explored further. Thank you.
Thank you for those very interesting cases and how molecular diagnosis can basically help you in further planning. Everything is not basically what you see actually. So a lot of hidden things are there which you need to identify with this molecular diagnosis. So any comments, questions? Yeah, Dr. Arif, I specially called him from downstairs. Please come to our session.
Yeah, thank you. I'm sorry I missed the very beginning of it. Very nice presentation. I just want to make one comment. I don't, you have a lot of presentations in this session. But just because that a variant is found in a gene, it doesn't mean that it's pathogenic. And I think when I came in, you were talking about a KIF21A variant and a patient with fibrosis and some brain abnormalities. I'm not aware of any KIF21A, variations associated with
Yes,
with
that's
brain
what I was
abnormalities.
also surprised.
So just that calls into question whether or not it's pathogenic. And also, most of the variants in KIF21A that cause strabismus are in the same residue.
Yes, I want to like to show the.
I don't want to take too much
pathogenic.
time.
It was showed pathogenic. The result came as
Did
pathogenic.
we test the family members?
The family members were not tested, but there was a 4-generation family history.
Sometimes the predictions are not correct. That happens sometimes. So, that's why the clinician is so important. The other thing I would say is, I think you were talking about a patient with Robo3 and vertical strabismus. I've never seen that. I would question that also.
So I have like 2 patients now, the ROB gene positive, the same similar kind of congenital.
Yeah, it's very interesting. I'm not saying it's not the cause, but we always have to be skeptical, because just because there's a change, even if it's predicted as pathogenic, it's not always the pathogenic. Thank you.
Thank you.
I'll just make a comment. I just want to say that traditionally we don't tend to test these patients through genetic testing, and so we're not quite aware of the kind of the wealth of phenotypes that can be associated. So I want to just labor that it's a good thing to do these genetic testing. As Dr. Khan just said, sometimes you have to interpret the results carefully, but the more you test, the more we'll understand what the basis is of this. So it's actually nice to see that you're doing that. And what kind of genetic tests were you doing?
We do a whole exome sequencing.
Just quickly add that I've also looked at the HGPPS, like Dr. Khan was there at APOS when we had the posters. So with that, if you can additionally test the parents and you can confirm that the biparental segregation, then you know for sure that you are dealing with a Robo3 mutation, or if there's any additional scoliosis that is presenting over time. Maybe when you do a whole exome, you can also do a parental segregation at the same time if you're clinically highly suspicious. So I know it's not easy to get blood samples all the time and get it tested with the cost factor that we have to deal with. But just do all both the parents and the affected at one sitting. It will just be very clear to you.
Right.
You have a question? You have a comment? A question? Yeah.
Hi, great cases. So what?
Can you use the mic, please?
I might have missed it. That in case 1, the CNS abnormalities.
We are present in KIF21.
Yeah. How was it showing up in the child?
They were there was thinning of splenium of the
like
corpus.
in terms of symptoms.
Symptoms, the patient didn't have any other
Fine, he was
symptoms.
fine.
He was just slightly low vision and
Okay. Yeah. And no history of any brain abnormalities
No.
or nothing in the
No.
family. Okay. So maybe it could also be that your genotype is cleaning part of the phenotype, and then the rest is sort of. So yeah, I mean, again, reiterating that maybe going up the generations with Sanger could give you some more information. Thanks.
Thank you very much.